While everyone's settling down, I want to wish everyone a very, very warm welcome to our CCDS annual symposium this year. Thanks everyone for joining us here today. We have an exciting lineup of speakers over today as well as tomorrow. If this is your first time at the conference, you will find a printout of the agenda in your bag, in your tote bag. If you haven't grabbed a tote bag, you will need to come up front and grab your name bags as well as a tote bag that has all of the information you need to get you oriented to the symposium itself. Also on each table, you'll see that there's a small paper holder, for lack of a better word, that has a QR code for an app which you can install on your phone. And the app also has all of the information about the agenda, events that are happening in between, and the like. So get yourself oriented to what's going to happen over the next 2 days with those 2 pieces of information. I'm excited to kick off things today with our very first speaker, Heidi Wallis. Heidi doesn't need an introduction, but she is the executive director of the Association for Creatine Deficiencies. She's been serving in this role for several years, and Heidi will deliver the opening remarks for today. Heidi?
All right. Good morning. Yes, I love symposiums, and it just is such an emotional time. And I hope everyone feels that all weekend. The genuine connection we have in our everyday cause to help our children, and the wonderful people here that are dedicated to helping those children that don't even have anyone affected in their family. This is just such an amazing group, and I hope you all feel a connection with everyone around you. I had some housekeeping slides, and I think Sangeetha covered quite a bit. If you're looking for the restroom, it's out this door just across the breezeway. And the kids camp, if you're wondering what's happening with my children, I think and hope they are in very good hands. They've been working for months to plan lots of activities. They have some really great people paired up with your children. So I hope your children make lots of buddies, both grown-up buddies and the other children in the symposium. The ACD store is back in this corner, and I just wanted to call out that we have little pins. So today I'm really going to focus on how far we've come with 4 symposiums, and we made a pin for every symposium we've had. Please go back there, they are free. We want you to wear your flare and show everyone all of the symposiums that you've been to, and so please go pick those up and visit the store. The auction is in this back corner, and I just wanted to call out that the auction does close tomorrow evening during the gala, and there's some competitive bidding going on some really good things that were donated to us, so don't miss out there. And like Sangeetha said, make sure you've got your welcome bag and your name tags, and if you're missing anything, if you need anything, just reach out to us. Our staff has a little staff on their name badges, and there's quite a few of us, and in fact, I would love for the staff to stand up and get a nice round of applause for months and months of work. So with that, I'm gonna run down today's agenda. It's a lot going on. It's a full day. We will hear from Hannah Polari from Revity, who will give our keynote presentation on newborn screening. And then we will also wrap the day with the plenary talk, and we will wrap the day with a keynote from Emil Kakis from Ultragenics. Following our meetings in this room, and we will stay in this room throughout. All of our meals will be here, so you don't need to worry about where things are taking place. we will have a poster session. So you'll get a little break from 4:30 to 5:30. We'll wrap at 4:30, come back at 5:30, and the posters will be set up in the back of the room. You can view those, talk to the presenting authors, and dig in on some of the topics you're going to hear about, or even some folks that weren't speaking but have brought some really interesting breaking data. And then following that, we will have dinner in here at 6:30, and about 7:15, we're going to invite your children, all children, to go out into the breezeway, and the researchers have a really fun activity. We've got some special gifts from Mr. Beast. They're going to be wearing their lab coats and their safety goggles, and they're going to help these kids do a really fun experiment and leave with some really special toys. And then I've called an audible. No one in this room knows, but I would love at 9 o'clock to invite anyone who wants to come back. Maybe your kids are adjusting and they're not gone to bed. Bring them with you. It can be loud, it can be crazy, but we're gonna watch Life of Lucas, a beautiful documentary about little boy Lucas who is affected by CTD and his parents and their mission. And so we're gonna do this 9 o'clock tonight. We'll see you here. If you want some help with your kids, we've got a lot of the folks from the kids camp who are here staying. So maybe your children have found a little buddy. They could be hall monitors and be walking the halls, literally listening to monitors. Any way that we can help, let's get creative. So one or both of the folks in your household can be here tonight and join in that. So with that, I do want to point out this is our largest symposium. We have about 250 people here, which is just incredible. And I thank you and respect you so greatly for the sacrifice you've made to be here. We have 8 researchers. That 8 number doesn't belong there, but hey. We have 26 researchers and clinicians. We have 15 institutions and 12 industry partners, all represented here from 6 countries. We have families from 8 countries, and there are 52 families here. So if you're wondering, what are the demographics? We've got 39 families with CTD children, 12 with GAMT, and 1 with AGAT. And 18 of those families are first-time attendees. In fact, probably half a dozen have received their diagnosis in about the last 6 months. And they just got right on it, and they're here. And they are looking for hope from all of us. From ACD, who is so committed to driving change and supporting all of you doing the research, and the researchers here who are going to be sharing the progress they've made and the commitment they have. So some growth since 2024, the last time we met in person. We've had over 75 new families join our community. The rate of folks at least finding us, we can never be sure how many are being diagnosed out there, but it's grown astronomically. And at least every week, there's a new family that we're meeting and helping through the process of learning what's out there and helping show them that there is hope. We recently announced $1.1 million invested in Race for a Cure. So since our last meeting, we launched Race for a Cure. We raised the funds, thanks to all of you, and we had the very innovative and very competitive applications for research projects and landed at the 3 that we announced, who you will be hearing from: Stanford, Johns Hopkins, and Berkeley. And we have had 11 different fellowship grants since we last met. And I also just want to call out, we've had dozens of families travel across the US and internationally to go to Boston Children's to participate in FNIRS. We have FNIRS here again at the symposium. We did 2 years ago, and they're going to be sharing a lot of the work that they've done and the findings that they have so far. So, you come to these meetings, it's a special feeling, it's great, and then you go home and You deal with issues in the lab. You deal with behavior problems at home with your kids. Life goes on, right? And so I want to issue a challenge that you don't just go home with good feelings, but you take something home with you that is lasting and that you feel will make an impact, because everyone in this room has made this event possible. They have driven every bit of research that we're going to hear about today. You are all tremendously important. Researchers, please, throughout these meetings, ask yourself, how could I accelerate my work? Can I work in parallel? And not wait for the next thing? Are there things I could be doing that I'm waiting on that maybe I don't need to go so slow? No insult, but can we think outside of the box? And can I network here? Could I be a mentor to anyone? Because we have new people in this space who are for the first time working with animal models of CCDS, et cetera, et cetera. Can I help anyone by being open with the research I've done? Can I, in fact, publish my work and make it available to people that aren't here but are working in this space? Industry partners, please partner with ACD. We create a funnel to receive feedback from our families and give that data to you to help you. We've created the core outcome set in collaboration with people around the world, and we challenge you to implement that core outcome set in your clinical trial design, and for your clinical trials to be inclusive of phenotypes, of different sexes, of different ages. How can you include the most patients in what you are doing? And then parents, you can join the registry. Your data is very important. Actively join the registry. So every survey that comes out, take the 20 minutes and get her done so that we can be actively sharing the voice of the patient. You can donate biosamples to Coriell. Just this morning, I heard researchers talking about working with patient fibroblasts. They got that because people in this room donated different biosamples, and those are stored and they are used actively. And then last, fundraise. If you are interested in Walk for Strength, we've got shirts here. You can sign up, you can register. It is not too late. All of this is because our families fundraised for us. So with that, I will wrap, and we will, for the next 2 days, race for a cure together. Thank you.
Okay, it's my pleasure to invite onto stage Brittney and Kevin McKittrick to kick us off on this day of sessions. Brittney and Kevin are parents to Sonny, a 6-year-old boy with CTD, and his younger sister Murphy. They live in Minneapolis. Sonny was diagnosed with CTD at 20 months of age following genetic testing after an acute onset of tonic-clonic seizures. Through his diagnosis, the family also learned that Sonny has a heart condition called prolonged QT. Sonny is described by his parents as the happiest, most present boy they know. Brittney and Kevin are also part of the Parents 2.0 project. Over to you both. Thank you.
Oh, you want that? Okay, thank you. Hi, how's everyone doing? Good. Well, Heidi, thanks for letting us chat and chat about our boy, Sonny. So this is Sonny, and he is our 6.5-year-old who has CTD. He was diagnosed when he was 20 months of age after an explosive onset of seizures. So we're going to chat about him and kind of some meaningful changes and challenges that we would like you guys to know. But before we do that, I think we should just introduce ourselves. So I'm Brittney. And this is my husband, Kevin. We live in Minneapolis. We've been there for about 5 years. We were there for a couple of months. We had moved there a couple of months into that. Sonny was diagnosed with CTD. And so we kind of have had this journey in Minneapolis, which we are really grateful for based on the level of support and care that we have there. We have a 14-month-old daughter named Murphy who seems to be typically developing so far. We did IVF with her. We tested for CTD and went through all of that just to do our best to try to keep her safe as possible. And her and Sunny have a wonderful, probably very typical brother-sister relationship, a lot of love-hate, but very, very more loving relationship. So going into Sunny and a little bit more about him, he just finished his first year of kindergarten. He has been in adaptive swimming. He loves to swim. He loves all things that have wheels, cars. From, 4 months of age, he would see a car and it would take his attention. So cars are his favorite things, books. I think one of the most special things about Sunny is his ability to connect and interact with people. Although he can't verbally talk to us, he has an unbelievable ability to connect with people. I think we've seen that a lot in the kids here so far this weekend, which has been really cool. But these kids Sunny strives for connection and attention. It's kind of what he needs in the morning to fill his tank in order to kind of get through the day and be level and level-headed. But Sunny is just a wonderful light. I mean, you can see it in his smile. He's truly one of the happiest guys he knows. But he is ready to go. I mean, he is 110% energy from the time he wakes up until the time he goes to sleep, and so that requires a lot of support. He doesn't have safety awareness. He is not potty trained. He requires one-on-one support always, so eating, getting down to sleep, changing, bathing, all of those things. So there's a lot required there, but I think his dad and I are so grateful for how amazing he is that it's not an issue for us, of course. So Sunny, after he was diagnosed with CTD, it was kind of a relief because we had a lot of questions early on. He wasn't sitting up, he wasn't crawling, then he wasn't walking, and we had heard, I think we probably all heard things they're maybe on their own time. They'll get there. And then you kind of know in your gut something's not quite right, but you're the one who has to kind of drive for those answers. So after we had those onset of seizures, we went through genetic testing and waited about 6 weeks to get that diagnosis. But while we were waiting, we got a call from, I think, his pediatrician saying that he had prolonged QT. And that was kind of a different kind of shift because we were focusing on one thing and now there was a heart condition that we had to think about. We didn't really know what that meant. It felt more urgent actually than the CTD. We needed to get him on meds and make sure he was safe. So that's been about 5 years. We're coming up on 5 years. Luckily, knock on wood, we've been almost 5 years seizure-free. So we're really proud and happy about that. Through the journey, Sunny has had a really severe hypoglycemic event, which I would love to chat with any parents who maybe have experienced this because we haven't found this to be something that has happened before. But he had a very, very low blood sugars when he was about 2 years old and was hospitalized for that. And that never happened again. So we don't really know what that was for. But he's, doing great. Prolonged QT, so his diagnoses, aside from those two things, are intellectual disability, which he got through a neuropsych eval when he was 5. He has epilepsy, of course, prolonged QT, and he's nonverbal, so he's got his challenges, but he's amazing, and we're just grateful for who he is every day, even though there are hard moments. There are not hard days, there are hard moments. So with that, I think I'm going to hand over to Kevin, but I'm going to set the framework up just briefly for him about us and why we wanted to chat today. So similar to Jill, Kevin and I have a very interesting perspective on CTD and rare disease. I think there's kind of 3 points to this, is that I've been working in drug development and clinical research for the past 15 years. So I actually work for a rare disease company doing clinical operations, and I oversee 2 programs of rare disease, trying to get these treatments to patients like our kids. And my husband here is a neuropsychologist, a pediatric neuropsychologist like Jill, so he is seeing these patients as well. So when we got this diagnosis, we were already on this journey in our careers, and it made us take a really big step back. And so I think that the lens that Kevin is going to share is going to be from that lens of having the career kind of baseline and then stepping into being parents of a kid with a rare disease. So with that, I will hand over to my husband.
Yeah, thanks for letting us talk. Yeah, thanks for letting us talk. Yeah, like Brittney said, that is our lens when we're thinking about, this journey that we're on and sharing and meeting new families. I think for us, the worries really involve two categories. First one being kind of the medical complications that can be associated with these conditions. And I think that's primary for us. In addition to that, and obviously related, are the developmental concerns, the intellectual disabilities, the difficulties communicating, the difficulties with emotion regulation, behavior regulation that can really just, set him apart from his peers and set us apart as a family, as you all know. And I was thinking about this talk and sort of what the prompt was, which is, what do I want, the researchers in the room to know in an elevator pitch? This is a long elevator ride. We're sorry about that. But just briefly, as a neuropsychologist, I'm thinking 20 years from now, if this patient were in front of me, what would I want to communicate to them? What would I want to offer them to support them in their life? And the first thing I think is do what you can to meaningfully, reduce the risk of these medical concerns. That's primary for us. The developmental pieces are important. They're secondary. We can handle the developmental pieces. I think for us, we have enough resources and understanding to understand this trajectory and what to do for him and how to help him in that regard. That's secondary. And then the third piece would be to understand the psychosocial impacts of this condition. I think that's a piece that's not often, or maybe is a little bit not talked about as much, but how are the parents doing? That affects treatment, that affects, people's follow through. It affects their quality of life and the overall well-being of the family. What does the community around a kid look like? Is it just? Is it supportive? Is it inclusive? These things are all related, and we can sit here and talk about kind of medical interventions to treat, get creatine to the brain. That's a piece of the puzzle. These other things I think are important too. So we could stand here and talk forever about this, but I'll leave it there. And I just want to thank you all for being here, and thank you to the parents for bringing their kids along. I think this is just a really important place for us to be right now. So thanks.
Questions?
Our next speaker is Dr. Nicola Longo. Dr. Longo is one of the key opinion leaders in the space of CCDS and a member of our Scientific and Medical Advisory Board. Utah's loss was California's gain. After 23 years at the University of Utah, he recently joined UCLA, where he serves as a professor and vice chair of human genetics and the chief of the Division of Clinical Genetics at the David Geffen School of Medicine. He's also one half of the CCDS medical power couple. His wife is Dr. Marzia Pasquale, who has done a lot to advance diagnostics in the field of inherited metabolic diseases. Dr. Longo himself, his interest spans disorders of fatty acid oxidation, carnitine metabolism, as well as brain creatine deficiencies. His talk today will set the stage for our next 2 days with an overview of CCDS.
Thank you, Sanjit, and thank to all of you for being here so early. What I will do today, I will not present much new, but I will try to draw conclusion on what we know, so we are all starting with a similar background. So these are my disclosure. And what I will do today, I will describe the origin and the function of creatine, will define the diagnostic approach to cerebral creatine deficiency syndrome, and discuss the effectiveness of newborn screening for GAMP deficiency a little bit. So first of all, why do we need creatine? creatine was initially found more than 100 years ago, almost 200 years ago, as a component of meat. And that's where the name comes from the Greek name of meat. And the structure of the molecule is shown here. But what it is important to understand is what creatine does. Usually, we produce high energy chemical bonds within mitochondria, which is the organelle which is shaded in light blue there. And the problem is that from the site of production, it needs to move to the site of utilization. And this is, which is outside mitochondria, it is in the cytoplasm. And this is done by the creatine system. So what happens is that the high energy bond that contains energy is transferred to creatine, and then we generate creatine phosphate, which can move to the cytoplasm, regenerate ATP, which is the high energy molecule that all the body uses, and then allow its utilization. Now, there are a series of enzymes that are called creatine kinases. So creatine kinases are the ones that phosphorylate and dephosphorylate creatine, are the ones that are necessary to allow the utilization of energy. And strange but true, if we have mutations in this gene, animals actually tend to do pretty well even without a creatine kinase system. We still do not understand all of the vagaries of it. I think that, that it is possible that we are still missing genes in the system for which the lack of one is bypassed by an alternative creatine kinase system. But from what we know so far, we still do not know of true diseases due to the lack of the creatine kinase system. Now, let's go back a second. How do we get creatine and what do we do with it? So the creatine kinase, what it does is simply convert creatine to phosphocreatine, and you can see the chemical structure there, back and forth. And basically, when we generate creatine back from phosphocreatine, we synthesize ATP, that it is utilized. When we generate phosphocreatine within mitochondria, we utilize ATP and we generate ADP. Again, this allows the transfer of the energy. What it is important to know is that creatine and phosphocreatine are spontaneously degraded into creatinine. Creatinine is the one that is measured by many tests that we do routinely when we go to the doctor. And creatinine is usually utilized as a measure of kidney function because it is just excreted in urine. If our kidney fail, the creatinine will become elevated. Now, what happens if creatine is converted to creatinine? That we need to replenish the creatine that it has been degraded. How do we do it? We do it by diet, and obviously creatine is present in meat, dairy products, is not present in vegetable, and from biosynthesis. Biosynthesis is important because obviously it still replenishes a significant amount of creatine. Keep in mind that one big steak contains about 1 gram of creatine. We need to replace 2 grams of creatine a day as a minimum. So basically, the synthesis of creatine is something that we do every day, even though we have no idea that we are doing it. The second thing is, where is the creatinine coming from? Most of the creatinine comes from the degradation inside cells and tissue. Why? The concentration of creatine in plasma is about 30 micromolar. Micromolar is 10 to the minus 6. Inside tissue is 20 to 40 millimolar, 1,000 times more, 10 to the minus 3. So the vast majority of creatine is inside tissue, the muscle, and the brain as well. Obviously, the brain, we don't, there is not much brain, but the brain contains a lot of creatine as well. So that it is why we need to replace it, because the creatine inside tissue is degraded and need to be replaced. Now, how do we replace it? So again, the synthesis is described here, and all of you are aware that there are two different enzymes that are responsible for the synthesis of creatine. The first one is called AGAT, or arginine glycine amidinotransferase, that utilize arginine and glycine to produce guanidino, acetate, and ornithine. And then the second reaction, which is GAMT, guanidino acetate methyltransferase, adds a methyl group using adenosine methionine and synthesize creatine. At this point, creatine utilizes the creatine transporter to enter all cell and tissues. So obviously, if we have deficiency of AGAT and GAMT, we have the disorder of creatine synthesis. If we have disorder of the transporter, we have creatine transporter deficiency. Now, how do we diagnose? So first of all, we were first diagnosed because by magnetic resonance spectroscopy, the peak can, one of the major peaks in the MR spectroscopy cannot be seen. You can see in the bottom tracing that there are three major peaks in normal brain. One is called N-acetyl aspartate, the second one is creatine, the third one is choline. Choline and creatine are pretty much the same height. Now, people started seeing that there were individuals with no creatine peak, and that it is the hallmark of the diagnosis. That's how the first few people were diagnosed. That peak was missing as people started looking, why is the peak missing? But we can diagnose the disease also biochemically. How? By measuring creatine and guanidino acetate in plasma and urine, and we will follow that in 1 minute. Now, what happens if the creatine system is missing? The symptoms are most of the time prevalent in the brain. The brain is the tissue that suffers the most of creatine deficiency. The presentation is similar with all of the syndrome, with intellectual disability, autistic behavior, and many times seizure. And obviously, this persists with time. Now, why the brain? Because what happens is that it is easy to transfer creatine inside the muscle. Is it easy to put creatine inside any tissue but the brain? The brain is both creatine transport and creatine synthesis for optimal function. If one of the two is defective, the brain is predominantly affected. Can the muscle be affected? Yes, it can also be affected, but the brain is always affected in every individual with one of the brain creatine deficiency syndrome. Now, the different syndromes are slightly different in terms of clinical presentation. AGAT deficiency, muscle symptoms are more prevalent. In creatine transporter deficiency, there are also symptoms that related, seizure are more prevalent. And in GAMT deficiency, that can be extremely severe. The second thing is that there can be what we are learning from the registry, that many individuals, especially with creatine transporter deficiency, have problem growing. They have gastrointestinal symptoms. We do not know why, but obviously they are present and might reflect an effect of creatine on the intestinal function that is still not fully characterized. Now, how do we diagnose this condition? There are guidelines that were published almost 10 years ago on the diagnosis of this syndrome. From a biochemical standpoint, we measure creatine and guanidino acetate in plasma and urine. And what happens is that in disorder of creatine synthesis, plasma is the preferred substrate. Because creatine is low in both conditions, but guanidino acetate is very low in AGAT deficiency and very high in GAMT deficiency. I'm saying that plasma is the best sample. They could potentially be seen in urine, but so many people have been missed by studying urine only that the guideline, in my opinion, need to be revised to update that plasma it is necessary. Even today, in the era of newborn screening, when people obtain confirmatory testing, sometimes they have conflicting results between plasma and urine, and they do not know what to do. What one needs to do is just utilize plasma for the diagnosis of disorder of creatine synthesis. On the other hand, plasma creatine and plasma guanidino acetate are completely normal in creatine transporter deficiency. In that condition, we need to study urine creatine and guanidino acetate. And in creatine transporter deficiency, the urinary excretion is increased. So we utilize urine for the diagnosis of creatine transporter deficiency, and we utilize plasma for the diagnosis of AGAT and GAMP deficiency. One non-specific finding that is present pretty much in all of the creatine deficiency syndrome is that level of creatinine can be low in plasma, not 100% of the time, but obviously if they are persistently low, one has to start thinking that it could be one of the creatine deficiency syndrome. So creatinine level in plasma can be a non-specific indication that there is a disorder of creatine synthesis. Now, what do we see in the different type of conditions? So we start with AGAT deficiency, which is the most rare among all of them, and muscle symptom can be the predominant, and now in a few patients, the only symptom in patients with AGAT deficiency. Now, it is important to diagnose because supplementation with creatine alone can improve the symptom and lead to a normal life if the syndrome is diagnosed very early in life. Now, what do we see in the lab? Here you see a lot of black dot and red dot. So the red dots are the ones that are being found in individuals with AGAT deficiency. And what you see, you have level for guanidino acetate and creatine in plasma, which is the top, and in urine. And you can see that in plasma, the level of guanidino acetate are always below the normal range. Creatine, it is usually below the normal range, but in some occasion it can be normal because people sometimes take supplement. So low level of guanidino acetate is really the key to diagnosis. In urine, you can see that there are some black dots. Black dots are normal individuals that mix with the red dots. That it is why sometimes the diagnosis can be missed when urine is utilized as the only system for diagnosis. And obviously with creatine there is even more overlap. What we know now that we didn't know many years ago is the fact that AGAT enzyme is highly expressed in the kidney. And in general, the kidney produces a lot of AGAT, makes a lot of guanidino acetate that travels to the liver, where it is transformed into creatine. Why is it important that there is so much AGAT in the kidney? Because there is one disease which is caused by mutation in AGAT, which is autosomal dominant. What does that mean? There is so much AGAT in the kidney that there are mutations that make the AGAT protein precipitate. It makes like something wrong that it is included inside kidney cell. And this causes damage to the kidney. When you have this type of specific mutation, you are perfectly normal, you have no muscle syndrome, no brain symptom, but you present with kidney failure. And by the time that you are diagnosed, it is too late. So obviously, you need to have only one mutation in this gene to develop this type of syndrome. I only have one patient with this type of syndrome. He was diagnosed at age 48, very normal person, and he was found to have high blood pressure, renal failure, and when you look at the biochemical lab, actually there were low level of guanidinoacetate. Why is it important to diagnose? Because if you give creatine supplement to this patient, you suppress, you decrease the synthesis of the AGAT enzyme, and you could delay kidney failure. So what I would recommend that every person who has a child with AGAT deficiency be tested for kidney function and also for guanidinoacetate level, because if they are too low and if they have especially some type of mutation, that could be at risk for kidney failure later in life. Guanidinoacetate methyltransferase deficiency. The big difference of this condition with the others is the fact that in this condition, not only you have the lack of creatine, but you have the accumulation of guanidinoacetate, which is toxic on its own. So as a result, therapy requires not only to provide creatine, but also to reduce the synthesis of guanidinoacetate. How? The way that we reduce the synthesis of guanidinoacetate, now I need to go back, is by doing in a couple of different ways. So guanidinoacetate is produced by the AGAT enzyme. The way that we reduce the activity of the AGAT enzyme, we give excess ornithine. When we give ornithine, this enzyme reaction will go backward because it sends too much ornithine, so basically it reduces the synthesis of guanidinoacetate. The second thing that we do, we use a protein-restricted diet to limit the content of arginine. And that's obviously, we reduce the arginine, and we reduce the rate of the reaction. We increase the ornithine, we get the reaction to go backwards. And then we also try, sometimes, we limit the amount of glycine that some patient is on the high end by giving sodium benzoate. Not everybody requires it, but if it is elevated, it is an additional strategy that we can use to reduce the formation of guanidinoacetate. With this strategy, we can reduce levels of guanidinoacetate. And the level of guanidinoacetate that we get at diagnosis reflect the severity of the metabolic block. Here what you have the usual graph with patient with GAMP deficiency with level of guanidinoacetate on the top panel. And you can see that the level of guanidinoacetate are quite high. The highest level here is 25, 27. But usually we have seen many patients that at time of diagnosis had level of guanidinoacetate around 20. With the normal level is, depending on age, is up to 2, 3, something like that. What we want to do is to reduce that to around 5 or less. That is what we like to do, to reduce the risk of a problem caused by guanidinoacetate. And we achieve that by the supplement, the diet, and everything else. This therapy is very effective. It started early on. Again, on the bottom, you see the urine testing, and you can see that there is a considerable overlap between the black dot with normal, with the blue dot that are GAMP deficiency. That's, again, why we should use plasma for diagnosis and follow-up of individual with GAMP deficiency, not urine. Now, here the therapy is explained again, showing again the reaction. And I have some goals in my clinic. Usually we try to keep the creatine level around 400 micromolar or above to allow adequate entry of creatine into the brain. And then we also have goals for ornithine level and for arginine and glycine. But basically, the bottom line, we want to reduce guanidino acetate to reduce the toxicity from it. And probably together with guanidino acetate, there are other guanidino compounds that might be toxic for the brain that we want to reduce. So again, the outcome is great if patients with AGAT and GAMP deficiency are started early in life on therapy. The reason being, and the way that it has been done so far, was based on family history. Patients were tested because a sibling had the condition, and they were started on therapy early on. But since this was effective, there was work to determine whether GAMP deficiency would be detectable in newborn screening blood spot, and it was indeed detectable, and there was a lot of work done to work with newborn screening program and with the Association for Creatine Deficiency to enable inclusion of GAMP deficiency on the expanded newborn screening. And this happened in 2023. I already remember, it is 3 years ago, man. So, but now every state, it is supposed to start screening for GAMP deficiency, and most states are doing that or moving in that direction. California started about a year ago, still has not identified any patient. Keep in mind that part of it is still technically challenging for some states to do the screening because it depends on who does the screening, how it is done, and how it is conducted. But that it is what it is happening, and hopefully this will allow early identification of all individuals with GAMP deficiency. In theory, we should be able to identify even individuals with AGAT, but nobody has yet been tested or identified. And obviously, guanidino acetate would be elevated in GAMP deficiency and low in AGAT deficiency. Now, the last one, creatine transporter deficiency, where you miss exactly the molecule which is indicated on the bottom. Again, that allows the creatine that has been synthesized to enter inside the brain and every other cell. But again, in the other cells, in the periphery, entry may be facilitated because there are, to get inside a neuronal cell, you need a series of transporters, not just one. You need to go across multiple membranes. That is why the brain is hard to reach by creatine. But again, when you lack that transporter, what you have that the brain does not receive sufficient amount of creatine. This disease, unlike the other two, is inherited with an X-linked pattern, meaning that it is carried on the X chromosome. Male only have one X chromosome and usually are more severely affected. We are finding more and more females that are affected by creatine transporter deficiency. Usually, they are not as severe as male, but they still are affected, and they could possibly benefit from early diagnosis and therapy. This is the most frequent of the creatine deficiencies. We still don't have a definitive count. We need to wait a few more years of newborn screening to determine the frequency of GAMP. And from the registry data, this is at least twice as frequent as GAMP deficiency. So basically, we would have an idea of how frequent this is by knowing how GAMP is frequent. So, and these patients usually present in the usual way, with the brain is severely affected. Many of them have muscle weakness, and the weakness of the muscle probably extends to their intestine. That is why they have low intestinal motility, and they tend to have failure to thrive early in life. The problem with this condition, we still do not have a therapy that it is effective for everybody. Unlike the other two conditions where we have determined, what we can do, and the therapy, we know that they are effective, we do something for this condition, but some people respond, some others do not. So, and that it is what I think it is one of the goals of the association is finding a way of developing therapy that works for every individual with creatine transporter deficiency. So the therapy is different from the one that we do with everybody else. We give high doses of creatine, and what happens is that when you give high doses of creatine, you try to utilize transporter different from the creatine transporter to carry creatine inside cell. You increase the concentration, so a transporter that physiologically transports an amino acid might transport creatine even with a lower affinity. But since you give so much creatine, you increase 10 times the concentration of creatine in plasma, then the creatine might be able to enter. And some people, especially individuals who have residual creatine transporter activity, might respond to this therapy. The second thing, we increase the amount of glycine and arginine that we give to individuals with creatine transporter deficiency to facilitate endogenous synthesis of guanidino acetate and then creatine. Finally, some individuals have responded to betaine, some to S-adenosyl methionine. There are many other therapies that have been tried, but none of them that has been found to be universally effective. Now, here it shows the level of creatine and guanidino acetate in individual with creatine transporter deficiency in plasma on the top, and you see that they are pretty normal, except in individuals that are receiving creatine supplementation where they become elevated. And you can see that in the urine, the excretion of creatine is increased in this individual. So again, urine is the way of diagnosis creatine transporter deficiency, not plasma. Now, here I repeat that the urine is the only informative specimen, and urinary creatine excretion increases with supplements. So many times what we do, we have that we falsely diagnose individual at risk for creatine transporter deficiency because many people take supplements and they like to take them, and you know, they are very, very well around. Again, therapy and outcome, we don't have any real therapy that works for everybody. Cyclocreatine was very promising in the past, but what happened is that it was found to be toxic in animal model and discontinued from further consideration. One thing that I want to discuss 1 second is the fact that there are different types of mutations that cause creatine transporter deficiency. Many of them are called nonsense mutation. Nonsense mutation, what they do, they completely impair the ability of the body to synthesize, in most cases, RNA and obviously the transporter. But there are other mutations that what they do, they cause a single change in one amino acid. The protein is made, it's just not functioning. Why it is not functioning? In many cases, this protein needs to mature to the plasma membrane, to the surface, and it is retained inside cell. And in theory, chaperone, which are small molecules that would bind to the creatine transporter during the synthesis, could favor the maturation to the plasma membrane. And one of them is sodium phenylbutyrate, which is a drug that has been used, we use consistently in patients with urea cycle disorder. Now, actually, in those patients, we reach a concentration in blood, which is about 1 millimolar, that could be sufficient to have a chaperone effect. So, in summary, what we have seen that disorder in creatine metabolism and transport can result in intellectual disability, hypotonia, and seizure. Agat and GAM deficiency impair creatine synthesis, whereas deficiency of the X-linked creatine transporter impair the entry of creatine inside cell. The diagnosis requires measurement of plasma and urine creatine and guanidino acetate. Plasma in disorder of creatine synthesis, urine in disorder of creatine transport. Low creatinine can be seen in some of these patients in routine testing. GAM deficiency can be identified in newborn. Therapy consists of creatine administration and supplement of ornithine and benzoate in GAM deficiency. And again, we try different supplements in creatine transporter deficiency, but none of them is universally effective. Thank you for your attention.
I have a quick question. So we've had newborn screenings identify patients, and I'm seeing this issue come up again and again, that the diagnosing lab and the clinicians are unfamiliar with this disorder, and they do the secondary test, the GAA remains high, and then they do another test, and they wait for the results, and they send out for genetic testing, and they wait for the results, and the family is very anxious to begin the creatine, give their child what they need. I wonder if you have an opinion on if the GAA is at a certain level or higher, and then 2-week screening again or confirmatory testing is a certain level or higher, do you recommend to go ahead and begin the creatine? Because some families wait for MRS, and it literally 10 weeks until they start diagnosis.
So the question is that there has been delayed in initiating therapy in patients with GAM deficiency. The recommendation is getting the lab and getting them up to speed. That it is the biggest issue. The technical competency of some of the lab is not the best. So what I do recommend every practitioner try to work with their newborn screening program to try to speed up the diagnosis, moving sooner to confirmatory testing rather than repeat screening. The reason that many labs do repeat screening is because they got so many false positives. And if you have good technical ability, the number of false positives is ridiculously low. But that it is the issue. So my recommendation: wait on on starting the creatine supplement. I would say that for now, 1 month of age would be acceptable. To me, acceptable is 2 weeks, but that it is the way I see it.
Do you have a number? GAA persists at 6 or higher? Would you give creatine while you await something like MRS or genetic? Would you go ahead?
No. Anytime, once you start getting the biochemical, once you get one initial confirmation that it is either biochemical, you don't need a brain MRS. I mean, yes, there are families that do not believe that their child has the disease. In those families, you need to do everything. But in the eye of the practitioner, if you have one type of confirmation that it is either genetic with DNA or biochemical or by MRS, you start immediately.
So I saw 3 questions, 3 hands raised. I'm going to do a quick run through of those 3 questions, and then we'll start the next session.
Okay.
Thank you. This is a great talk, Dr. Longo. I had a question about the creatinine levels in plasma and urine. Are you aware of the CSF levels in these patients? Are they also altered?
Sorry, can you speak louder?
Yeah. So you were discussing the low creatinine in the plasma and the urine. Are you aware of CSF values?
So the question is the CSF creatinine. I'm not aware. So, but actually, Dr. Schultz, they are low. Yeah. So, and in fact, what I'm trying to do now, I'm trying to see in patients who have all of these conditions, how therapy affects creatinine level. I'm collecting them, and what you see, I mean, for at least in GAM deficiency, you see that once you start giving the supplement, creatinine goes up. So creatinine really tells you that creatine is getting inside cell and getting metabolized, because again, the concentration is 1,000 times different between outside and inside. If you can get creatinine to go up, I believe that it is an indication that something is working.
Our next question is here.
Hi, Dr. Longo. For supplementation in CTD,
I come here.
okay.
Here.
For supplementation in CTD patients, we all are familiar with glycine, arginine, SAMe, and betaine. You mentioned that it's sometimes works. Is that mutation specific when it works? And do you have any indication of which and when to use?
The question is whether the supplementation is mutation specific. I wish I could give you an answer. What I've seen, I mean, obviously, all of us have limited experience. Mutation specific in the sense that there are sometimes mutations that in which creatine transport activity is not 0%, it's 10%, 20%. That it is where efficacy has been seen, at least in cohorts of patients in Italy and also in one of my patients. That it is my experience. The type of missense of mutation is a missense variant, a mutation in which you substitute one amino acid with another. The protein is made, it doesn't work great, but it is there. That it is what you can see.
No, it's fine. I can come to you.
Yeah.
Thank you. I enjoyed your talk and learned a lot. Another disease for which analogous defects in a transporter are known is cystic fibrosis. And as you know, there has been much progress in the last decade in the development of small molecule chaperones that improve function for patients with mutations in the cystic fibrosis transporter. So my question is are there insights that can be gleaned from that research effort that could be applied to improve the effects of small molecule chaperones so that they are better than phenylbutyrate?
Yes, so the question is, can we learn from cystic fibrosis? Yes, we can. There are a couple of issues, however. In cystic fibrosis, the prevalent mutation is a missense variant, so the vast majority of individuals have at least one copy of one mutation that will respond to therapy. Here, the vast majority of patients are male who only have one allele, and more than 50% have stop codon that will not respond to this type of therapy. So basically, the answer is yes, but it would still be limited and would not cover the majority of patients. The majority of patients have mutations that would not respond to a chaperone. Obviously, it would be nice to have, a big list of mutations, but I mean, in my clinic, the vast majority of people have stop codon, and stop codon would not respond to this type of thing. And just going back a moment to the cystic fibrosis, what is the difference between the therapy in cystic fibrosis and the therapy with phenylbutyrate? Phenylbutyrate is a non-specific chaperone, so it works with everything. Instead, what you need, the real chaperone therapy is where you develop a molecule that binds immediately with your protein of interest, in this case, the creatine transporter, while it is being synthesized. And in this way, it protects that one, but not thousands of other molecules. It needs to be specific for the creatine transporter and allow it not to be degraded.
We're going to do two questions. That's it. Two more. That's it. One there, one here. Go ahead.
Okay.
No, here.
You go.
Yeah. I come here.
Hi, Dr. Longo. Anyone can hear me?
Yeah.
No, it's on mute. Hey.
No, perfect.
Just a question my wife wants me to ask, because wives are so important in these situations. With GAMT, treatment doses, should it change with age or with a weight increase? So again, basically what it is, with, that's okay.
I need to turn off my phone. I do not know how
That's it.
Sorry,
That
sorry.
person is now gone. The question is with GAMT, should treatment doses increase with age or with weight increase?
We're talking about an adult.
Yes.
Jade's on 27.
You use the microphone,
please.
please.
Sorry. Well, here today, we've found out treatment is different for some families to ours. Our daughter is now going to be 39 next month, and she's on 29 of creatine, and so I've forgotten the ornithine, 4 times by 3, and your son is on 40 grams. I'm just wondering, with our daughter, her weight's increased, her age has increased, probably more on the weight level. Should the treatment go up? Should the creatine be higher?
So the question is on the dosage of the drug as people get older. Is that correct?
Yes.
For many of the pediatric disorder, we start when they are children,
Yes.
and we base our dose on kilogram of body weight.
Yeah.
And then people get really big and old, and then, you know, I think that there should be a standard maximum dose. That's how we do for adults.
Yeah.
We are not there yet.
Okay.
So basically, I wish I had an answer for you. So, but I mean, 40 grams sounds quite a lot. So probably there is a max dose that, you know, probably in terms of creatine, I would say, you know, 20 to 25 would be the max dose for an adult. And also with ornithine, one needs to pay attention. So the way that we determine the adequacy of the dose is measuring blood level. The way that we do, once you reach the target in blood, then you stop going up. Ornithine, it is strange because if you give too much ornithine, you stimulate the synthesis of arginine, that in GAMT deficiency, what it does, obviously it causes you to produce more guanidinoacetate. So ornithine needs to be really a little bit above the normal range. That's how I do. So, and then, you know, at the end of the day, you look at the guanidinoacetate. So you need to work by looking at the level of ornithine, at the level of arginine, at the level of glycine, and at the level of creatine to see to reduce as much as you can the guanidinoacetate while keeping the creatine around 400 micromolar. That is what you do. In other words, there is no single answer for a specific person. You need really to measure levels.
I think you've just confirmed for us that our metabolic team in Melbourne is doing the right thing. Because her GAA, we've never got it down below 5, but it hovers around, the lowest we've got is 5.8, but it hovers around 6.5, and they feel comfortable with that.
What level do they feel comfortable? Like what?
She's around about 6.5 GAA.
5?
6. Sorry, it's the accent.
6.5. I mean, it's not that bad. So.
Yeah.
But you know,
when I asked the question to them, they said, "Ask it to you."
Can I recommend a sidebar maybe for more detailed discussion?
Yes.
That's all right.
Sorry.
Thank you.
So.
We have one last question, I think, up front on this table.
Hi, Dr. Longo. So my question was just in looking at the chart of the different levels of creatine and where you can kind of see where they're high, normal, low. For CTD specifically, the creatine in plasma is normal. And so I guess my question is, which I was just talking to him about, so I think he might have given me an answer, but is why do these kids have hypotonia if their blood has creatine? And I think he was saying it was more of a neurological thing. But I was just curious about your input. Like, is there any can you share a little bit more about that, why these muscles are severely depleted of this creatine and ATP to be able to develop if they are maybe have access through the blood?
So the question is basically, why is the muscle not functioning? That there is all the creatine of this world right there. Well, let's start from the brain. If you look at the CSF, there is all the creatine that you want in the CSF there as well. So the problem is that it cannot get in. It doesn't get in fast enough. And the other thing is that probably in the muscle, you still need some. We don't have many data on muscle biopsy, but where is Dr. Schulze? Dr. Schulze is the one who has the most data on muscle biopsy, even in patients with creatine. Have you done muscle biopsy in creatine deficiency?
No, unfortunately, there is only one investigation that has been published in a patient with creatine transporter deficiency. And to my surprise and everyone's surprise, they reported normal creatine in the muscle. And there's absolutely no good explanation for that. That's why Gary Lipschitz and I had proposed to do a study. We'll not present this this year. May send our study protocol to Heidi, and then Heidi will communicate us to the parents. But the idea is to get perhaps 10 families coming with their child with CDD to either LA or Toronto. And then we would want to do a muscle biopsy. We want to do an MR spectroscopy. We want to do a PET scan. That's kind of another radiological test. We want to do also some tests of glucose metabolism, because Dr. Lipschitz had some evidence that there isn't disturbance of glucose metabolism. So, we heard today the hypoglycemia in one family. And then we would like to use the muscle samples not only to measure creatine. I mean, that is kind of the first question. Is it low or normal? And then we will see whether there is any kind of genetic compensation. That means we will do gene expression studies, for example, to answer the question, is there a compensatory mechanism that kicks in the muscle? Because we would expect CDD is a condition that's a severe myopathy. That would be no muscle and no power. But that's not the case. Everyone who has a child knows how much power they have, right? So it is an invasive study. It means travel for the families. It means sedation, general anesthesia. It is at least once, most likely twice. So I would guess, we don't have a protocol ready, but it would perhaps be 3 or 4 days. So it is asked a lot for whoever wants to participate. But the gain of what we are learning may be very relevant, because if we understand what the muscle is doing instead, then we perhaps have a tool to apply to the brain.
Our next talk will be given by Dr. Kim Cecil. Dr. Cecil is not able to join us in person, so she has very kindly pre-recorded her talk, which we'll be playing for you today. Dr. Cecil is a professor of radiology, pediatrics, and neuroscience at the Cincinnati Children's Hospital Medical Center. Her expertise is in MRS and its application to imaging in pediatric brain disorders. Notably, it was her recognition of the near absence of creatine on MRS that led to the first patient diagnosis of CTD. So we'll be playing Dr. Cecil's video. As you can imagine, because we're running a little bit behind, this talk will eat into our coffee break. I encourage you to go and grab coffee so we can, through the talk if you prefer, so we can continue on with our next session right after that.
Hi, everyone. I'm Kim Cecil, and I'm sorry I can't be there in person with you. I am the MR spectroscopist at Cincinnati Children's Department of Radiology, and I'm going to speak with you today about pediatric magnetic resonance spectroscopy harmonization. Proton magnetic resonance spectroscopy, abbreviated as MRS, is part of an MRI-based methodology. It is non-invasive like MRI, but it may require anesthesia for your child or loved one to undergo it, so they remain motionless in the MRI scanner. We can measure many neurochemicals, and we must do this in a prospective fashion. So when you get an MRI or your child gets an MRI, they do not automatically obtain spectroscopy. Spectroscopy must be ordered, and regions of interest in the brain must be sampled in order to collect a spectrum. So here I have a sagittal slice from an MRI study, a coronal slice, and an axial slice. And this yellow box represents the region of the brain where we're purposely acquiring MRS data. This is an example of an MRS spectrum illustrating some of these key neurochemicals: N-acetylaspartate, glutamate, creatine, cholines, myoinositol. This is an LC model output, which will be useful information later. Well, what are the benefits of MR spectroscopy? We know that select diseases have unique diagnostic spectroscopic profiles. The cerebral creatine deficiency syndromes, Canavan's disease, and several others have these spectroscopic profiles that really help a radiologist make the diagnosis. What we're hoping is that MRS can provide metabolic information about individual responses in the brain for patients with treatable diseases. And that's why it's used for conditions like multiple sclerosis, some infection, and other metabolic disorders. Creatine and phosphocreatine are the key chemicals of interest to us. And let me just focus you with a spectrum on them. So here's a typical spectrum, and this is a fitting of the creatine and the phosphocreatine, which these two chemicals are very similar in their structure, just differing by having a phosphate group, which means we are not going to be able to see the changes at MRI field strengths commonly used, 1.5 Tesla and 3 Tesla. For this methyl group is at 3 parts per million. This part of the molecule appears here. And then this other portion of the molecule at 3.9 parts per million appears on the spectrum here on the end. And when you have a phosphate group, you can see here just a slight color differentiation of phosphocreatine and creatine. As you go to higher MRI strengths that are typically not used in the clinic, you can start to separate those peaks. I also have some fitting of glutamate and glutamine in this example. When we have a patient with creatine transporter deficiency, we see this creatine resonance, or the two creatine resonances, dramatically diminished. What we don't know yet is this residual creatine, or is this some other neurochemical that is appearing there? As I mentioned, other examples of diseases that have unique spectroscopic profiles is Canavan's disease. And in Canavan's disease, you get an accumulation of N-acetylaspartate. So instead of a diminished peak, we see a dramatically elevated peak. And we notice the peak at 2 parts per million the most. There's other smaller components of the NAA molecule that get buried underneath our spectra. So what are the challenges of MRS? It's not a routine method because not every MRI study of the brain needs it. It provides limited information, just those handful of chemicals, and there's some exotic chemicals that sometimes can be seen, but for most patients, it just provides a limited amount of spectroscopy metabolic information, and it's very nonspecific in most cases. So a change in NAA, a reduction, is a very nonspecific finding. So many injury processes, many disease processes will reduce NAA. And historically, we thought that creatine was stable. So we thought we'd be seeing creatine and phosphocreatine together, and that would be a stable compound, and we know it's not now. MR spectroscopy requires more patient history to be effective. So you need a radiologist reading the study who's aware of the patient history and know what question to ask of spectroscopy and what it expects spectroscopy to be answered. So knowing more patient history is sometimes a challenge. It employs distinct steps for acquisition, processing, and interpretation. Though its basis in MRI is the same, the way you acquire it is different than an MRI. As I mentioned before, you have to be prospective. You have to actively turn on certain water suppression, localization of the region of interest. You have to do special shimming. You have to do special processing afterward. It's not the same as how images are generated. And then, of course, interpretation is different. Where a radiologist is used to looking at structure, this is different metabolism. Thus, it requires specialized training and expertise. MR spectroscopy, since it is not done with every MRI scan, the vendors produce only so much, they only provide so much support for MR spectroscopy, which is limited. And but this is the biggest challenge. It is applied inconsistently across imaging centers. So each site can use different sequence parameters. They can sample in the brain in different regions. And even when you're trying to sample in the same location, when you have 30 different technologists, they're going to slightly adjust it differently, which sometimes can have a big impact. So let me illustrate this to you in an example. So this is a 7-month-old male who has infantile spasms as noted on EEG, and spectroscopy was performed. It's the same patient, the same exam, same region of the brain, but I've changed one parameter, and that's called echo time. So it's how long after you do turn on the spectroscopy sequence and you listen for your response. It's 35 milliseconds for this spectrum, and this one is 288 milliseconds. And I had the technologist select these times for various reasons. When I don't know the patient history, I'm trying to evaluate many of these chemicals. So I'm looking for lactate, and you can see here the lipids are a little bit elevated on this sequence, but on this one, it's very flat. So if lactate was buried underneath there, I would want to use this sequence to make that decision. But as you can see, just qualitatively, this region's a little different. This region is a bit different between the two. And the key thing I want to illustrate here is in this example, creatine is our tallest peak, having the most area. And in this example, it's one of the lower peaks where NAA and choline are much higher. So if I were participating in a clinical trial and I sent one of these spectra, it has a different implication than the other. So if I'm mixing them with all the other spectra from a multi-site trial, we need to be doing the same types of things. And again, with the vendor challenges and these different parameter changes, it can have a big impact. And sometimes when a radiologist is scanning a child who may have a cerebral creatine deficiency syndrome, they're not going to know that in advance. So they may protocol it for one type of sequence that may not really be useful to us down the road when we're doing a natural history study or a clinical trial trying to use existing data, because we don't want to sedate our children any additional times than needed. So let me talk about quantification. So ideally, the metabolite signals are fitted to measure the areas, not just peak height. In that example I gave you, the line widths were the same, so I could infer that the peak heights information about quantification. But ideally, we want to measure areas because some of the vendors do not keep the widths of those peaks the same. So we want to measure areas, and then we have to adjust for those sampling conditions. Size of the volume of interest, the echo time. There's other parameters that get changed across sites that we have to adjust for. And then the composition of the voxel. So where the voxel is positioned in the brain, we need to know how much gray matter, white matter, and CSF is in that voxel. So we can convert our ratio values to the water concentration. For diagnosis, the metabolite concentrations are plotted against normative levels acquired using the same parameters, same location, and then we adjust for age when we take a collection of individuals that we know have typical brain development. For clinical trials, we would want to measure the change in concentration from essentially identical sampling over time. That's our goal. So what's the real world look like? Well, not all pediatric radiologists have access to normative data for diagnosis. So sometimes their information base for making a diagnosis is limited. For neuroradiologists knowledgeable about the cerebral creatine deficiency syndromes, there's some confounding things that happen. As I pointed out, there's some residual signal at 3 parts per million. And so some radiologists mistakenly think that there must be no signal there. So they may not call a creatine deficiency syndrome because there's still a residual peak there. And sometimes when they sample at those long echo times, as I showed you, the creatine signal drops. And that's just a phenomenon about creatine in an MRI scanner environment. When you sample long echo times, it's completely the same amount of creatine in our patient in both of those assessments, but it's just how the assessment reads the creatine concentration. So that can be a false positive. People will call a creatine deficiency just because they're sampling long echo and then they just notice that reduction. For natural history trials, a lot of times the spectra is not provided. The radiologist, the radiology center will just give you the report. And so they don't, and sometimes those reports do not have technical information about what sampling conditions and the individual patient results. What are those ratios? Otherwise, we could try to use some of that data. So let me show you some examples of cerebral creatine deficiencies again. This is the short echo technique. So here's a GAMP deficiency patient and a creatine transporter deficiency patient. And you can see both have dramatic reductions of creatine. Look at both peaks at 3 parts per million and the other one at 3.9. Sometimes you can notice an elevation of guanidinoacetate, but not always. So that is not a diagnostic marker that's reliable enough. And again, there's just different appearances for the creatine peak there. There's potentially GABA and some other amino acids that reside there. Let me take the creatine transporter deficiency patient spectra. This is the short echo. This is the long echo. So sometimes it's a little bit harder to measure. So when we're doing a diagnosis, the short echo that I just showed you here with GAMP and CTD is probably the best to use. But for quantification and for quantification, the long echo, while it's a simpler spectra, would be harder to quantitate because there's just noise adjacent to the creatine peak in this example. And because of what's known as T2 relaxation decay, which is again part of a normal MR phenomenon, this signal is much lower. So short echo for diagnosis and treatment monitoring is the way to go. So let me show you also an 8-year-old female with creatine transporter deficiency who is severely affected. On this short echo spectra, the qualitative assessment could call this spectra unremarkable. There's creatine there, it doesn't really look off. But when you look at where this was sampled, and it was actually sampled in the basal ganglia, this choline peak should not be higher than creatine in the basal ganglia. So that requires someone very familiar with their sampling location, what typical is supposed to look like, to really alert them. And when you go to long echo, the creatine level is much lower than what it should be, independent of the T2 relaxation decay, where, as I've been emphasizing, the creatine is lower. And then when you do a quantitative analysis, you can take the LC model output, you can make corrections for the conditions and reference to water. Then you can appreciate there's a 40% reduction of creatine in this brain region for this female patient with CTD. So the real world, though, oftentimes there is only semi-quantitative analysis relative to creatine levels. And what I mean by that is vendor supplied, measure the area under each peak and compare them to one another. And that's standard software that the vendors provide on their scanners. It's very difficult to monitor treatment response from changes in the voxel positioning and the brain maturation. And both the numerator and the denominator can change when you have relative levels. So there's a lot of things we have to adjust for when we're really trying to get true levels that the real world doesn't provide us in the clinic. And that's just, again, in part because spectroscopy is applied rarely, and it's applied rarely in these rare disorders. The storage of individual patient spectroscopy has been problematic because saving the raw spectroscopy data requires a different process. And unless you have an MR spectroscopist or a physicist who's focused on spectroscopy, they're probably not going to collect that data that's needed for subsequent post-processing corrections, parameter adjustments, as I've mentioned. So with all that as background, how can we herd all these cats and make recommendations so we can avoid unnecessary sedation and additional imaging procedures and cost, so we can collect data from patients? What we're recommending is first that there's an acquisition of a 3-dimensional T1 weighted imaging sequence. And this is done to determine the amount of gray matter, white matter, and CSF within the voxel that's being sampled. And this should be a part of any typical MRI exam of the brain. And then we're proposing a single voxel spectroscopy sequence that uses that same 3D T1 weighted sequence to position the voxel of interest. And we expect that because the 3D sequence is part of a typical imaging exam, we will not add any additional burden in time to the study. So there should be a 5-minute acquisition time that we're recommending to pediatric studies that are evaluating children with neurodevelopmental delay prospectively. So our MR sequence parameters, we're recommending that voxels be 15 millimeters per side in infants up to 12 months, and then 20 millimeters per side for children and adolescent. We're choosing a different location, but a location we think we can more reliably obtain across sites, across technologies, across the country, across the world. So the voxel location is midline visual cortex within the occipital gray matter in patients without a suspected white matter involvement. Prospectively, when you don't know if a child's going to have a creatine deficiency syndrome, a radiologist may have more suspicion of a white matter disorder, so we can allow placement of the voxel in the parietal or frontal white matter. We're at this time recommending a point-resolved spectroscopy localization method until some other methods are approved by all the vendors. At this point, the press method is FDA approved. It's available on every single scanner in the country and hopefully in the world. We are also asking that outer voxel saturation pulses be applied. So this can minimize tissue from outside our region of interest contributing to our signals. So let me show you what these look like in the brain. So this is an axial slice with this particular one is set up for 15 millimeters per side. This is the sagittal. And if you can see, there's a little triangle here. and that is the occipital lobe. So we thought this region would be the easiest. Put the voxel kind of in the center of that triangle, and then this is the coronal slice of that. So we'll want to stay away from, there's a sinus here, but this midline acquisition gives us mostly gray matter as well. So here for a white matter concern, parietal white matter and the corresponding sagittal and coronal slices of that, and this is the frontal on the axial positioning as well. So you can see sometimes the eye there causes problems. The sinus can give us problems with some of these regions, which is part of why we typically don't want to recommend that for a large clinical trial. Our sequence parameters, and I apologize, this is a little bit in the weeds. We're recommending short echo acquisition times of 35 milliseconds, repetition time of 2,000 milliseconds. We're asking radiologists to signal average 128, collect a water reference so we can quantify compared to water, use 8 signal averages, and we're, if possible, set the parameters to store individual shots. So in the event the child moves for some reason, those shots could be removed and we could still use the data. At this time, we're asking for standard site processing with the vendor or other software as the radiologist uses the spectra in the evaluation of the child. We ask that they store the 3D image and spectra in DICOM format, and then we will be able to use that if the child has a creatine deficiency syndrome and wants their data used going forward. The DICOM files can be shared for multi-site studies for uniform processing, and we will do subsequent quantitative post-processing with fitting and those corrections using those DICOM files in a future clinical trial. For quality, so sometimes you have to throw out data because the spectra just doesn't have sufficient quality. So we're asking for a minimum signal ratio of 15 of the N-acetylaspartate metabolite, line widths of 10 hertz or less. When they are fitted with LC model, values of errors of 20% or less, be free of signal artifacts. Again, in certain locations, you'll get a big scalp artifact, or if you do not suppress water sufficiently. We've prepared a manuscript and submitted it to the American Journal of Neuroradiology. That's the title, and my co-authors, Dr. Henry, Heidi Wallis, Dr. Thurm, and Dr. Roberts. Our work was funded through the PCORI grant, and I thank you for your attention, and I hope to be present with you to answer questions. Thank you.